Welcome back to the second part of anemia. We're going to be starting this video today with thalassemia. And some of the things you need to know about this disease is that there is a quantitative defect in hemoglobin. In particular, we can't make enough of the alpha or beta globin chains. And the severity of this disease is variable. Our red blood cells become hypochromic and microcytic in this type of anemia. So with thalassemia, there is a genetic defect in hemoglobin synthesis, and that defect causes us to have a decrease in the amount of hemoglobin produced. So we can't make either the alpha or the beta chains. And since there's an imbalance of the globin chain synthesis, this leads to lower hemoglobin production. And then we have ranges in severity from asymptomatic to incompatible with life. Most of the people who will have thalassemia are from African, Asian, and Mediterranean heritage. So with thalassemia, one of the things that you do see are these hypochromic, microcytic red blood cells, and then you also see these very distinct teardrop looking red blood cells. The oxygen is going to be low in a person's body because obviously they don't have enough hemoglobin, and so this becomes very apparent in the first 6 months of life. And if left untreated, the individual is going to die. So the hypochromic or pale, abnormally shaped red blood cells, you can see them pretty distinctly here also. And the darker cells are most likely normal red blood cells here, possibly from a blood transfusion. This is just showing you those hypochromic red blood cells again. One of the other things that we see in thalassemia is what's referred to as medullary expansion. Now, medullary expansion is caused because the bone marrow is expanding, and of course you know this is where our blood cells are produced, and the bone marrow is trying to expand because it's trying to compensate for that chronic anemia. So we're going through increased erythropoiesis, or at least trying to make more red blood cells. The only treatment for thalassemia is stem cell transplants from a bone marrow, as well as simple transfusions. Because the red blood cells are going through hemolysis, there may be excess iron in the system, and so chelation may also be effective to some extent. And what happens is a chemical is added to the blood that's able to bond to that iron and decrease the iron load in the body. So this is just another picture showing thalassemia. And so if you look through here, you see the hypochromic microcytic red blood cells. You can also see some of the teardrop type of forms of red blood cells as well. Hereditary spherocytosis is another type of anemia, and one of the things about this is that there are tons of spherocytes seen in the blood. There's a defect in spectrin, which is the protein that helps to maintain the shape of the red blood cell, and then one of the potential, you might say, cures for this is a splenectomy. So what's happening with this spherocytosis is there's a defect in the surface membrane, especially with that spectrin of the red blood cells, and it causes the red blood cells to kind of ball up in shape. And because of that ball shape, there is a decrease in the surface area of the red blood cell, disproportionately to the intracellular contents due to that loss of protein. So the decreased surface area of the red blood cell impairs the flexibility of the red blood cell. So as the red blood cell is going through the spleen, through its microcirculation, the red blood cell is experiencing hemolysis. And so removing the spleen could decrease some of the issues here. This is the most common type of hemolytic anemia in people of Northern European descent. And this just shows you some of the spherocytes. And here is a good case of splenomegaly due to this hereditary spherocytosis. Another issue is glucose 6-phosphate dehydrogenase deficiency. This glucose 6-phosphate dehydrogenase is an enzyme that helps to prevent oxidation of the red blood cell. And so it causes the red blood cell to be maintained instead of breaking down or going through hemolysis. So in this deficiency, the red blood cell is missing this enzyme. All right, so things you need to know about this glucose 6-phosphate dehydrogenase deficiency. When this enzyme is low, there's an increase in peroxides being produced in the cell, and the increase in peroxides cause the cellular lysis. So this enzyme typically protects the red blood cells against oxidative damage. It occurs almost exclusively in males, which is kind of interesting. So why do these red blood cells die? Well, they can't reduce the peroxides in the cell, and those peroxides attack the hemoglobin, and the heme breaks away from the globin. So the globin is denatured and it sticks to the red blood cell membranes in what is referred to as a Heinz body. Now those Heinz bodies can be removed by cells in the spleen. And it actually looks like the red blood cells have had little bites taken out of them. So this is just showing you what the glucose 6-phosphate dehydrogenase does, and you can take a look at these whole steps if you'd like to. It helps in making NAD production in the pentose pathway in making ATP. These are the Heinz bodies where the globin is attached to the cell membrane. And then you can see these are the little bites that has happened to these red blood cells because the cells of the spleen have removed those Heinz bodies. So some of the clinical findings, some patients are asymptomatic. Others have episodic hemolysis. And there can be some triggers. For instance, there are some veggies called broad beans that can trigger this in some men. Drugs, some antibiotics, aspirin might be triggers. And then it can have spontaneous resolution. So you can see that jaundice is one of the outcomes of this deficiency. So 3 ways to become anemic. We talked about loss of blood or losing blood, destroy too much blood, make too little blood. So too few building blocks. That would also have to do with iron deficiency anemia. And things that you should know about this, it's the most important cause is due to a gastrointestinal bleed. The red blood cells are microcytic and hypochromic, leading to that type of anemia. And so you have to find out why the patient is iron deficient in order to be able to cure this disease. And again, you know that iron is part of our hemoglobin molecule, and we have iron right here. And without that, oxygen can't bind. And these are red blood cells that are iron deficient, so you can see that they're definitely hypochromic. One of the most common effects of iron deficiency anemia is swelling of the tongue. And the tongue can actually swell so much that when a person's talking, they end up like biting the sides of their tongue, and they can also end up biting like the sides of their lips, or their lips can start to tear, and it's very uncomfortable for the individual. And then you can see there's peeling of the tongue also that can occur. This is also from iron deficient anemia, where the fingernails curl up and begin to peel away. Causes of iron deficient anemia: there's a decrease in iron intake. So the person may have a very bad diet, or maybe they have absorption issues, like for instance, maybe there's a gastritis issue or some type of gastrointestinal distress. And again, the number one cause would be a gastrointestinal bleed, but menses can cause this as well as some kind of other hemorrhage. And then women can become iron deficient during pregnancy. So anemia of chronic diseases such as infections, inflammation, malignancies can occur. If there's some disturbance in iron metabolism, the red blood cells can be normochromic and normocytic with this, and the anemia is usually mild. The next anemia is megaloblastic anemia, and things that you should know is this is defective DNA synthesis in the red blood cells, and so the number of red blood cells is lower than normal. This can be due to a vitamin B12 and or a vitamin B9, which is folate deficiency. And the red blood cells are much larger than they should be, so we have a macrocytic anemia. And then also white blood cells, the neutrophils, are hypersegmented. So the retarded or the slowed down DNA synthesis with the unimpaired RNA synthesis causes our red blood cells to become very large, but they're immature as far as the nucleus is concerned, with a mature cytoplasm. And so you can see the very large red blood cell here in this megaloblastic anemia. Also the hypersegmented neutrophils. And swollen tongue, glossitis, is a big issue with megaloblastic anemia as well. Now, vitamin B12 is very important to prevent this type of anemia. But vitamin B12, what it does is it helps to work in the conversion of the amino acid homocysteine to methionine. If you don't have vitamin B12, you can't do this conversion. And in order for that vitamin B12 to do the conversion, it has to be a form of vitamin B12 called a methylated vitamin B12 or methylated cobalamin. Now, in order for vitamin B12 to be methylated, you have to have folate. So folate, which is vitamin B9, has to produce the methylation of vitamin B12, which then converts homocysteine into methionine. The reason you want homocysteine to turn into methionine, well, there's a number of reasons, but one of the big reasons is that the elevated levels of homocysteine have direct correlation with cardiovascular disease. So the higher the homocysteine levels, the greater endothelial damage occurs, and so atherosclerosis can increase and thrombosis can increase. Now, a decrease in myelin, if you don't have enough of this, methionine, a decrease in methionine can cause damage to myelin. And of course, without methionine, you can't produce a number of proteins. And so you could also see degeneration as far as the nervous system is concerned. So if I don't have enough vitamin B12 in my system, I might have what's referred to as pernicious anemia. Now, pernicious anemia is actually an autoimmune disease. And in order for me to be able to absorb vitamin B12, I have to have what's called intrinsic factor. Intrinsic factor is produced by the parietal cells in the stomach. And the autoimmune component is that the person's immune system can produce antibodies that destroys the parietal cells, and that leads to pernicious anemia. So pernicious anemia is then a decrease in red blood cells because you can't absorb vitamin B12. Your red blood cells are macrocytic, but they're normochromic. There's an increase in mean cellular volume, but there's a normal MCHC. Common causes would also be due to lining issues in the stomach. So if I had gastritis, I might not be able to absorb the intrinsic factor or the B12. And then we talked about this being an autoimmune disease. And then mitosis in the bone marrow of the progenitor cells is suppressed, and this is another issue. So symptoms of either pernicious or megaloblastic anemia would be diarrhea in some people, or constipation, fatigue, loss of appetite, pale skin, shortness of breath, but this is mostly during exercise, that swollen tongue, bleeding gums, neuropathy. Those are all symptoms of that type of anemia. So 3 ways again: loss of blood, destroying too much blood, and then too little blood, and this could be due to too few erythroblasts. The next type of anemia is called aplastic anemia, and things you should know about this are pancytopenia occurs, and that's an abnormal depression of the cellular elements in the blood, so there's not as many, and you have what's called empty bone marrow. So this is a blood smear in aplastic anemia. See if you can pick out some unusual happenings in this before we start talking. Here you can see what's called empty bone marrow, where all of these cells are fat cells and they do not belong in the bone marrow. This is where our red blood cells and all should be made. Some of the causes of aplastic anemia, idiopathic. Certain medications, viruses, even pregnancy can cause this. And so the body stops actually producing enough new blood cells. Signs and symptoms could include fatigue, shortness of breath with exertion, irregular heartbeat, tachycardia, pale skin, prolonged or frequent infections, increased bruising, nosebleeds or bleeding of the gums, prolonged bleeding from cuts, skin rash, dizziness, headache. So this is a bone marrow that is full of fibrosis, which is not a good thing. You have fibers moving in and taking over the bone marrow so that red blood cell production can't occur. This is normal normal bone marrow. And if we go back here, you can see the difference with empty bone marrow. And then here is another example of bone marrow with aplastic anemia where the fat cells have moved in mass, and now we're not making red blood cells. So factors that can temporarily or permanently injure bone marrow and affect blood cell production would be radiation, chemotherapy, toxic chemical exposures such as benzene, which you get in gasoline when you're exposed to gasoline, certain antibiotics, other medications, could be an autoimmune disorder, viral infections, Epstein-Barr, cytomegalovirus, parvovirus, HIV, pregnancy, and then, of course, idiopathic aplastic anemia. Treatment would be blood transfusions and bone marrow transplant if possible, stem cell transplant, and then certain medications that can stimulate bone marrow production. polycythemia is an elevated red blood cell level in our blood. And we have primary and secondary polycythemia. Primary polycythemia is caused by an abnormality of the cells in the bone marrow that form red blood cells. So these cells, for whatever reason, are producing too many red blood cells. Secondary polycythemia is caused by a disorder that originates outside of the bone marrow, and that causes overstimulation of our normal bone marrow, and now we produce too many red blood cells. So with primary absolute polycythemia, stem cells in the bone marrow proliferate without any signal from erythropoietin. And so this could be like, for instance, a benign tumor of the marrow. Secondary absolute polycythemia is increased red cell concentration in the blood with normal plasma volume. And this is overproduction of the erythrocytes by the bone marrow, but erythropoietin is elevated, and that elevation could be due to, for instance, you go to high altitude and experience hypoxia. You could have renal tumors. There could be restricted blood flow to the kidneys, and so hypoxia has occurred in the kidneys, and all of this is elevating erythropoietin levels, and now you can see all the excess production of our red blood cells. So some other terminology I'd like you to know with bleeding disorders, petechiae. These are pinpoint hemorrhages that you can see under the skin and even behind the sclera of the eyes. You may be able to see petechiae post-mortem in the organs. You can see it in the brain, for instance, very well. And then you also have purpura. This is larger areas of bleed, sometimes less regular, that's underneath the skin. Ecchymosis is even larger areas, over 2 centimeter area of bleeding, so like a really huge bruise. And then a hematoma, which is a large volume of blood trapped in the soft tissue. So you know that platelets are going to be responsible for helping to form blood clots. And platelets help to produce these tiny little fibers called fibrin that can crisscross and form a mesh that traps our red blood cells, and these mesh can form a clot or it can harden and form a scab. So about 150,000 to 400,000 platelets per millimeter cubed in the blood is normal. So this is, notice the large macrocytic, somewhat clumpy, dark-colored, hypochromic red blood cells inside the oval marker. Red blood cells with such shape and color are conspicuous indicators of pernicious anemia. Probably should have had that in the pernicious anemia portion. Thrombopoiesis is the production of platelets. And platelets are derived from cells that are called megakaryocytes. And these megakaryocytes fragment, or some people think they explode or they bud, but whatever, they form platelets. Now, just like erythropoietin, which is helping to form red blood cells, thrombopoietin is going to stimulate megakaryocytes and their production as well as differentiation into those platelets. And thrombopoietin is formed mainly in the liver, a little bit in the kidneys, similar to erythropoietin. The role of platelets is to help to form a plug. So you have this person who they're bleeding, and the platelets are going to be exposed to a breakdown in the endothelial lining. As the platelets are being drawn towards this open wound, this bleeding, the platelets are going to start to stick to fibrin, which is trying to make that kind of crisscross hash-like pattern underneath the surface of the blood vessel in order to clog things off. Now the platelets start adhering or sticking to this fibrin, and they do what's called degranulation. And that means they're going to release ADP, that adenosine diphosphate, and that promotes even more platelet activation. And we start to get a positive feedback. The platelets stick, they release ADP, that allows more platelets to stick, and so on until there's a plug that forms that helps to stop the bleeding. There's also some thromboxane A2 that helps to promote that platelet activation and the sticking of the platelets. So you can see here, this is that in that pink color they've dyed it. This is the fibrin where red blood cells and platelets are going to be trapped in there in order to form that blood clot and that platelet plug. I think this is a really cool picture. This is a picture of a platelet, not a chocolate chip cookie. It's an electron micrograph of a platelet. Now, in order to dissolve unwanted clots, what can happen is there are certain enzymes such as urokinase that is able to dissolve that clot. That's made in humans naturally, but for instance, streptokinase, this is made by Streptococcus, and it can also dissolve clots. And of course, clots are important to stop bleeding from occurring. Now, to prevent coagulation from occurring, you have to stop fibrin from forming. And in order to do that, you also want to decrease that platelet plug. And so there are several different things we can use. For instance, Coumadin, that blocks vitamin K, which is necessary to form a blood clot, to form fibrin. EDTA is a chemical that binds or chelates calcium, and calcium is also needed in preventing clotting. And then aspirin also prevents that thromboxane A2 from forming, so it helps to prevent the platelet plug. So there are some disorders of platelets. One is thrombocytopenia, and this is the inability to mount an adequate hemostatic response. So you have insufficient levels of platelets under 100,000 per cubic millimeter, and it may result from suppression of the bone marrow due to certain medications like thiazide diuretics and antibiotics, but also chronic alcohol abuse, tumors, and then even dietary deficiencies of folic acid and vitamin B12 can cause thrombocytopenia. There's also something called idiopathic thrombocytopenia purpura, and this is an autoimmune disease where you have petechiae and purpura that are coming about, and usually this is brought on by a viral infection, and the antibodies that are produced are not allowing for platelet production to occur. And this is thrombocytopenia. That looks very painful. So we're going to talk now about leukocyte disorders and start out with leukemia, which is a collection of cancers that creates a large amount of immature blood cells. And so we have gene mutations that cause these immature blast cells to accumulate. And those immature cells take up a lot of space in the bone marrow, and it prevents the bone marrow from making healthy blood cells like platelets, red blood cells, and white blood cells. So leukemia is a primary malignant tumor of leukocyte origin in the marrow, and proliferating cells in the marrow in varying degrees of differentiation spill over into the blood. So we see these immature blast cells also in the blood. Signs include susceptibility to infection, neutropenia, agranulocytosis, failure of normal hemostasis, which would allow for blood loss, thrombocytopenia, and it can metastasize to the spleen, liver, the meninges, and most commonly to the lymph nodes. So you have this normal bone marrow And in leukemia, you have proliferation of these blast type cells. So the myeloblast and the lymphoblast cells that are going to not allow for production of mature red blood cells and mature lymphocytes. So looking here, you have normal cells, and then you have overproduction of white blood cells. And also, these white blood cells quite often are not effective at doing their job. So we have acute and chronic leukemia. And of course, we know that this is of the lymphoid cells, and acute versus chronic depends on the maturity of these malignant cells that are found in the peripheral blood. Immature cells allow us to know this is acute leukemia. And acute leukemia usually has an abrupt onset. It can be from infection, and symptoms can include anemia, infection, bleeding from thrombocytopenia, bone pain, and enlarged lymph nodes, enlarged spleen and liver, headaches, vomiting, or nerve palsies, and this is predominantly seen in children and adolescents. We can treat this with chemotherapy and with bone marrow transplants. Chronic leukemia is the most common of the leukemias, but usually we see this in people above the age of 50. The onset is gradual, the person feels fatigued, has weight loss and anorexia, and B lymphocytes are the most involved, and they're non-functional, so we have a deficiency in antibody production that occurs, so the individual can also be much more susceptible to infection. Now, lymphoma is a solid malignant tumor that arises from lymphoid tissue, and the tumor replaces the marrow and the lymphoid tissue. It is invasive. It does metastasize. There are immune deficiencies leading to infections and anemia, lymphedema, splenomegaly, and you can see here the different types of outcome of lymphoma. Now, we're going to talk about two types of lymphoma, Hodgkin's lymphoma and non-Hodgkin's lymphoma. So we'll start with Hodgkin's lymphoma. This is most often seen in young adults. It is usually a single painless cervical lymph node that is affected, but it can then spread to adjacent nodes and to lymphoid organs. And you'll be able to see what are called Reed-Sternberg cells. These are large multinucleated cells that are found in the lymphoid tissue, and these are unique to Hodgkin's lymphoma. Now, what causes Hodgkin's lymphoma, whether it's genetic or maybe some people have recommended or suggested that Epstein-Barr virus infection could cause Hodgkin's lymphoma, not really sure. Symptoms would be enlarged lymph nodes, often in the neck. Patient loses weight, usually due to anorexia. Night sweats, fever and fatigue, infections, and then radiation and chemotherapy usually can give permanent remission for Hodgkin's lymphoma. Now, non-Hodgkin's lymphoma is a malignant tumor. It arises in B lymphocytes. Lymph nodes are the primary site of this. And so if we look at Hodgkin's versus non-Hodgkin's, we know that Hodgkin's usually arises in a single lymph node, typically in the neck. It rarely involves other lymph nodes, and it's associated with defective T cell immunity. Non-Hodgkin's is able to spread widely. It's much more aggressive than Hodgkin's lymphoma. It can arise in organs and spread to other organs, and the brain, bones, and bowel can be involved, and it tends to spread widely from its origin. It is potentially much more lethal. Multiple myeloma. This is a malignant proliferation of plasma cells, and these cells are in mass in the bone marrow, and the nodules destroy bone and produce what's called punched out bone, so that you have basically holes in the bone, especially of the spine and the skull. And there is definitely a decline in immunoglobulins, and chemotherapy is usually not effective with this, and survival is approximately 3 years. All right, so that is the end of our video for today.